the physiology and respiratory physiology and the application of respiratory physiology in pathology of lung disorders. Uh, my topic is body plethysmography. Technically speaking, it's a very dry topic. It's a simple principle Boyle's law, but it's difficult to understand Boyle's law. We're not going to understand the physics and mathematics behind Boyle's law. We'll try to make the what is the application of body plethysmography. If one or two take-home messages that will be sufficient for us. Uh, when we have just saw the physiological recording of the body, कैसे हो गए ये हो नहीं रहा चेंज okay. We have seen in the previous lecture there are physiological parameters that we see during the spirometry. When after seeing the patients in our clinics, we many times ask them to go for the lung function test, and the basic lung function test is spirometry. And many parameters we see in this spirometry are flow rates, and definitely like the forced vital capacity, FEV1, and mid expiratory flow rates, peak expiratory flow rates, all these things. But many things are left that we don't see in the spirometry, like lung volumes, resistance, capacities. These are the things that have just saw in the previous speaker slide, and the tidal volume, the normal inspiratory, expiratory, inhalation, the tidal volume. Above the tidal volume, respiratory exertions with maximum effort is inspiratory plethysmography. To evaluate the obstructive airway diseases, to measure the airway resistance, when we breathe out or breathe in from tubes, then definitely flow creates a resistance. And to assess the bronchodilator response and hyperreactivity. All these parameters, all these are indications for the consideration of body plethysmography. Body plethysmography, in fact, the many things that we there are many parameters or many machines that we give the total lung capacity or lung volumes. These are the helium dilution methods, nitrogen washout methods, body box, and radiological. There are four mechanical equipments available through which we can obtain the total lung capacity at different volumes. One and two, helium and nitrogen washout, they are gas dilution methods. These are gas dilution methods, and the principle for gas dilution method in both cases they are similar. But one limitation of gas dilution method is that all of the airway or alveoli that are connected with the alveoli, when you take gas, that gas goes under dilution. These are not connected with the airway, there is no dilution. It means the part of the lung that is not connected to the airway, we don't measure that. This is the limitation of that. And the trapped air, in fact, trapped air is not measured by the gas dilution method. To solve this problem, the machine came that is called as body plethysmograph. The body plethysmograph measures whole gas in the lung. Either it is communicated or it is not communicated. In fact, like gas trapped in bulla, that body plethysmography collect all thoracic volume, total thoracic volume determination. Another advantage and disadvantage of body box is that it is a fast method to obtain the thoracic gas volume compared to the dilution method. And sometimes we see there is a uh, sometimes when the body box has false results, yeah, in fact we can say the little bit higher result than expected. If the FRC in COPD and asthma obtained may be little high, and if the FEV1 what we get from the simple spirometry, if it is less than 30% predicted, the body box results may be little bit high. There are three types of body box: the pressure type, volume type, and pressure volume types. The commonly performed body box, what we have in our labs, are mostly the first one, that is the pressure type. Many institutions, it's a body box is a costly affair. Many institutions don't have that. That Hemant have body box in his lab. KGMC, there's body box in there. I don't know how many body box are there in the different institutions, but it's a costly affair, government-owned affair. And that's why technically many times we don't see the body box results. We see this parameter, we see diffusion, but body box tracings are seldom seen. Most of the time we go by this machine, and these two machines are usually in the research labs are used. We are focus of this in the plethysmograph. This is the a box type of machine, clearly seen in this figure. It is a sketch diagram of body box. Body box is a box basically. Body inside box. This is a box made of plastic and some steel, which has a airtight cabin. It has two, three openings, and one there is a pneumotachograph. It is placed fixed on this wall. There are three shutters. This that is called, you can say, the transducers. Transducer one, two, and three, and one ball in the base of the body cabin. These transducers are connected with the computer. Technically, when the patients ask for body box, the patient's height, weight is taken, and patient is placed in the box, and the procedure is performed in the sitting position. Patient is asked to hold this mouthpiece in the mouth, and after applying the nose clip, he breathe in and breathe out through this mouthpiece. And during this procedure, the airway resistance is calculated. Meanwhile, patient before the procedure, he has been already explained what are the things that may happen during the procedure. In between, after the normal inspiration and expiration tracing, when the end of expiration, there is shutter here, and that closes. After the closure of shutter, the patient's pants like this. I demonstrate. Suppose I am patient inside box. This is big chamber. Nose clip on my nose, and mouth is closed against the shutter. I breathe like this. I can adjust panting effort. There is no flow actually, but respiratory excursions are there that is affecting our thoracic wall. We are changing our the thoracic volume by just panting, and the speed of panting is 1 to 2 per second. This is the usual rate of the panting. When we inhale, if we see this box, when we inhale, because box is an airtight container, after inhalation, the gas in the thorax increases. Gas in thorax increases, gas in lung, the same thing, gas in lung increases. The amount of gas increases in the lung, that reflected in the cabin pressure, the cabin volume. Suppose a 500 ml, just for example, 500 ml of air is inhaled. In fact, you have displaced your thoracic volume, the amount measuring of 500 ml. The 500 air of the cabin air is compressed, and pressure increases. But the pressure and volume calculation, pressure and volume product remain constant. This is the basic principle of Boyle's law. Whatever the pressure and volume is there, if the pressure is increasing, the volume is decreasing. The volume is increasing, the pressure is decreasing. And this is mechanism is repeated 4 or 5 times during the procedure. What happens when this procedure is going on? There are three transducer we see. Transducer one, this transducer records the pressure change at mouth. Once the patient breathe against the closed shutter, there is a patient pressure change in mouth occur, and that pressure change in mouth corresponds with alveolar pressure. Second transducer is placed here at the this pneumotachograph that changes that records the change of volume or flow during the procedure. And third transducer is placed here that records the cabin pressure. Whatever the cabin pressure changes are occurring, this is recorded by this transducer. All these transducers are connected by an amplifier because the changes are very little, and they get amplification, and these amplified results are connected to the computer, and they are placed against the x and y axis. We are the clinicians, we don't go what is the mechanism behind this. We use the application of the principles derived by Boyle's law. We are not going to see how this value came. This value is derived by the machine, and that time to time calibrated. These transducers are connected, as I say, connected to the uh, amplifier, and the amplifier is by the computer, and through the x and y axis we see the loops are there. Maneuver कैसे होता है? As I explained, there is a 3 to 5 breath per second, sorry, 1 to 2 pants per second होता है, and we see the 3 to 5 loops. Once we inhale and exhale, there is a loop forms because it is a closed chamber. We are inhaling and exhaling in a closed chamber. So there is a closed circuit. The loop forms as I see in a spirometry. When you trace the spirometry curve, that is a closed loop. Whatever the shape comes, but it is a closed loop. The closed loop forms, and once 3 to 4 loops with different similar shapes are recorded, the loops provide the thoracic gas volume. The shutter opens, and once the recording shutter opens, and the if we see the 3 FRC within a range of 5%, this means that is a accepted and repeatable curve. These are just recap. The patient sits in the airtight cabin, breathe in and out from outside cabin. There is a mouth. In case of body box, thoracic movements are recorded as a pressure change in the closed chamber, and these observations are recorded, convert into lung volume. Inside the cabin, the pressure transducer is there and record the pressure change in the cabin, and other pressure sensor is in mouth that record the flow at the mouth or alveolar pressure. The cabin is air closed compartment. Any change in the volume is just recap. P1 V1 is equal to P2 V2, and with all these measures and parameters, with lot of physical and mathematical calculation, the thoracic volume is the final result. We see as a final result is we give the thoracic volume that is not seen by the spirometry. These are calculated by this machine. We see the loops how they comes. This is the inspiratory limb of the loop, and this is the expiratory limb of the loop. When the patient breathe in, after certain time, there is a cessation of flow, and this is the tracing of airflow. This airflow is seizures here, and during exhalation, this is the airflow, and this again come to 0 point. So the loop is formed, and this loop give the idea about the uh, thoracic gas volume. Usually the loops are straight. Straight means not like this only, it's a horizontal line. Loops are straight. And in healthy people, if it is the obstruction, the loops get flatter. Flattening of loop decides whether it is restriction or the obstruction. We see in there are a few cases. In the healthy individual, loops are a straight line. Flatter the loop, the loop gives idea about the restriction, and flat curves indicate, sorry, flatter the loop is the flatter the loop, greater the alveolar resistance, and flat curve indicate obstructive physiology. This is the loop. This is the normal straight loop, and we see this second loop is more flat compared to the index loop. This loop goes in favor of obstruction. Once sometimes when we see the tracing, few loops come in this way, and few loops come in this way. When we see case 1 to 2 cases, we can differentiate what are the kind of disease that patient is having. After this loop tracing, we see the other parameter measured by the body box is airway resistance. Two important parameters. One has the thoracic gas volume, and another is the airway resistance. There are two important parameters: airway resistance and specific airway resistance. Airway resistance indicates that if it is the delta P, change of pressure versus change of volume, if the plotted against the curve, this gives the airway resistance. It indicates the airway obstruction, asthma and COPD. If airway resistance is increased, this is the seen in the obstructive airway disease. And once the airway resistance is plotted against the change of volume, tidal volume, that's give the specific airway resistance. Specific airway resistance and airway resistance, only difference is that the volume comes under consideration. Rest things are normal. Normal airway resistance and specific airway resistance means there is normal lung function. If there is a confusion, suppose the patient have poor effort, we go body box and see the airway resistance. If the airway resistance are normal, it means patient is having the normal lung functions. Airway conductance. Another terminology, once we see the airway resistance is reciprocal. Reciprocal of airway resistance is called as airway conductance. And if we plot the airway conductance in respect to tidal volume, it gives the specific airway conductance. The increased airway conductance or decreased airway conductance gives the idea about the obstruction or narrowing or caliber of the airway. What is the RV by TLC? Residual volume by total lung capacity. RV by TLC normal is 25 to 35%. Once it is increased more than 35%, it means obstruction. There is severity of obstruction, mild, moderate, severe, and once RVTLC is decreased, that goes in favor of restriction. It may be mild, moderate, severe. Way to measure the airway resistance. What are the techniques? How we measure the airway resistance? These are the esophageal balloon, impulse oscillometry, and body plethysmography. There are three ways how we measure the airway resistance. And when we require to measure the airway resistance in suspected case of obstructive airway diseases. Indications of measuring the airway resistance, evaluation of airflow limitation beyond spirometry. If the patient is not able to perform the spirometry or the poor effort, then we can go by their measuring the airway resistance. Bronchodilation testing, bronchial air. Should we hold continue? Around 5 7 minutes. These are the indications when we do the airway resistance measurement. Only for 5 minutes. Sir. Any machine, if not calibrated, we can't rely on the results given. The calibration is very common, and calibration should be done for every machine. Volume calibration should be checked daily using the calibration syringe, and the airway opening pressure transducer should be physically calibrated regularly. What are the contraindication of body plethysmography? Because as we see, the body box is a box-like structure. Any patient who has fear of closed space, that contraindication for putting the patient in the body box. Patient having mental confusion, patient is on continuous oxygen, and patient in IV infusion or intercostal drainage where the closed chamber is not maintained. The summary of the procedure that patient sits in a chamber, we breathe in and out against the open airway. This measure their specific airway resistance and airway resistance. Once the shutter is closed, that measures the loop, and these loop give the idea about thoracic gas volume. And these are the different tracing of the thoracic gas volume and airway resistance. Parameters for obstruction in a spirometry, as we see, the FEV1 by ABC gives the idea about obstruction. But in case of body box, this parameter is achieved by the airway resistance as specific airway resistance, and this doesn't depend on the patient effort. Repeatedly saying, if the patient is not able to perform spirometry with full effort, then we need this machine. And this is required for many times to differentiate between obstruction and restriction. What are the difference between restriction and emphysema? If we see, the vital capacity is reduced in both conditions, but vital capacity in emphysema is reduced at expense of residual volume. Because in emphysema, residual volumes are increased, TLC remains normal or unaffected. Whereas in restriction, TLC decreases, residual volumes either remain same or it reduced. There are few tracing. This is the one parameter that is usually many times required, as earlier told this. The RV by TLC normal age is 35 to 20 to 35%. If it is increases more than 35, it goes in favor of obstructive disease, and if it reduces, it goes in favor of LD. pneumonectomy, or lung volume reduction surgeries. There are few curves. See the curve. This curve is open here and direction towards the clockwise. If we see the parameters here, this is the resistance, specific airway resistance and airway resistance. These are the predicted is less than 1 liter, but it is 4 liter pre. The value is significantly high. It is 400%. And the direction of curve, and this is open here. Loop is open. Once loop is open, it indicates that the patient having the obstructive airway disease. And in case of obstructive airway disease, the resistance is always increased. See the residual volume. It is nearly 150%. 2.2, just double almost. And total lung capacity also increased. The same second curve, the direction of this is towards like anti-clockwise. In earlier it was like this, but in this it's changed. This, by seeing this, we can predict that patient having obstruction or restriction. In this case, you see the specific airway resistance 0.96, it is predicted, and P is 0.77. It is less than normal. You see the total lung capacity in this case, it's not seen here. Residual volume is 1.1 and the predator is, sorry, pre is 1.52. The marginally increased. And total gas volume, total thoracic volume is less. It means it goes in favor of restrictive. Because in restrictive disorders, the thoracic volume is reduced. Last case, the direction of curve is same. It looks like direction is anti-clockwise. The specific airway resistance, both are less than predicted. Residual volume, almost normal or equal to predicted or little bit less. Total lung capacity is reduced. This again goes in favor of restriction. So by seeing the curve direction and opening or closing of the loop, we can predict the patient having obstructive airway disease or restrictive air disease. The take home message in this case, the body box is required in many certain conditions, like if the patient cannot perform this parametry, if we have confusion about emphysema restriction, to follow up and diagnose the restrictive lung disorders, and to see the airway resistance. And with this, I stopping here. Thank you very much for patient listening.